Noah.
Yeah, okay. Thank you very much, Dr. Eletu. I hope you can hear me.
Yes, sir.
Loud and clear, sir.
Okay. So, yes, let me congratulate you first for a wonderful job you did in that PanConf um, conference. You and your very, very dynamic team, I think you did wonderfully well, and it was a successful. We thank you and we thank God for the success. It was a very, very good meeting. And I also congratulate you for being elected into the executive of PAN. You see, the reward for hard work is more work. So,
Thank you, sir.
so I am happy that you will do your best there, and you will use this opportunity to further see how pediatricians in private practice can mobilize and contribute more towards the activities of PAN and towards child health in general outside of their own practices. That is what this group is about. And, I'm so happy that you are there. I think during this period, we shall see very, very great things happening. So thank you for that. And I welcome our speakers. The speaker for today, Dr. Ofiaeli, Ogochukwu Ofiaeli. I hope I'm correct, yes? From Newi.
Yes,
yeah?
sir. Yes, sir.
Okay.
Thank you so much.
Very welcome.
Thank you.
The moderator we know very well, very familiar face, Dr. Akinola. You're welcome. I would not be surprised if today's meeting, if we don't have too many people, because after, I think many people will be feeling stuffy in their head after all the stuff they collected during the bank of. Some may just want to have a rest. Actually, I was pleasantly surprised when I discussed with Dr. Eletu some days ago about this meeting. I would have been happy to hear that, well, no, everybody's a bit tired, so let's keep this one. But I was pleasantly surprised when he said, oh, yes, it's already prepared, and there are speakers already. I said, you are very strong, So I congratulate the group for being able to put up this meeting, and I expect a very, very interesting lecture. So without wasting too much time of your time, let me hand over to the moderator, Dr. Akinola, to carry on with the proceedings of the day. Welcome again.
Thank you very much, sir. Thank you indeed. Esteemed elders, colleagues, and friends, welcome again to this session that will be taken by Dr. Ogochukwu Ofiaeli. She's a fellow of both colleges, the West African College of Physicians and the National Postgraduate Medical College of Nigeria. She's a senior lecturer in the Department of Pediatrics, Nnamdi Azikiwe University, and she established and currently runs the adolescent health as well as the pediatric rheumatology clinics at Nnamdi Azikiwe University Teaching Hospital. She has postgraduate degrees both in adolescent health as well as rheumatology. She's a very powerful woman. She's currently the president of the Medical Women's Association of Nigeria, Anambra State chapter. She believes strongly that whatever is worth doing should be done as excellently as possible. So please join me to electronically welcome Dr. Ogochukwu Ofiaeli as she teaches us for the next 45 minutes on what's the role of pediatricians, what our role should be with regards to adolescent obesity. Ma, you're welcome. I yield the floor to you.
Thank you so much. Thank you very much. I greet all my teachers and elders, senior colleagues and friends, and all invited guests present. Thank you for giving me this opportunity to speak to this distinguished house. It's quite an honor to be here today. So I will just quickly share my slide so I can keep to the time. I appreciate the honor and the opportunity given to me. Can you see my slides?
We can. It would be
Yes.
nice if you can put it in slideshow.
I will. I'm just okay, yes. So yes, so
Excellent. Thank you.
thank you so much. So we're going to talk about adolescent obesity and the role of pediatricians. I'm here just to remind us of some things we know. In fact, I'm so sure some of us know these things more than myself. So I'm just here to remind us, a little reminder for the house. This is the general outline of everything I'm going to say today. So by way of an introduction, obesity is a complex heterogeneous disorder that places individuals that are affected at increased risk for adverse mental and physical health consequences from excess body fats. It's a progressive and a relapsing condition. So you find people that are affected, they lose weight and they regain it after some time and then they lose it again. So it's a cycle. And in terms of adolescent care, the BMI is what is used for classifying, the most convenient way for classifying obesity, calculated as weights in kilograms over height in meters squared. Just to remind us of the age group of adolescents, the importance of these definitions is because these are transition periods of growth, and usually the choices that are made within this time, they can really affect the life course of the individual. So generally, adolescents are individuals that are aged 10 to 19 years. And the WHO also has further grouping to have the youth that are 15 to 24 and young people that are 10 to 24. And then when you come to the adolescents, they can also be categorized by age groups into early 10 to 13 years, mid and late adolescents. So this is a pictorial to explain or give further definition to the classification of obesity in adolescents. So moving straight to the 5 to 19-year group. For those that their BMI are above the 85th centile, if you're using the WHO growth charts, they are already overweight. And those that are above the 97th centile, they are already overweight. Now, if we want to put into perspective the risk for comorbidities with relation to this BMI classification, now, looking at the BMI alone and not with regard to the percentile chart, because sometimes you may meet adolescents that the BMI, especially those the early and mid-adolescent group, so they will look lean, they may look lean, but when you take the BMI, it would actually be underweight, but when you check it on the percentile chart, it will be within the normal. So that's why it's good to combine the two. So once the BMI is 25 and above, the adolescent is already overweight and is at increased risk for comorbidities. Once the BMI is 30 and above, that 30 is the obesity landmark. Then the risk for comorbidities increases exponentially. And the obesity group, they have 3 levels or 3 grades. And as you go higher, the risk for comorbidities increase. So you have the class 1, that is 30 to 34.9, class 2, that is 35 to 39.9, and then those that are supermorbid obesity, BMI of 40 and above. So I just put this pictorial for us to appreciate what I'm saying in terms of size. So usually the adolescents that are within their normal BMI, they look fit. They look fit as against those that look lean, they look fit. So the moment the adolescent is looking well nourished to any degree, if you check the BMI, probably that adolescent is already overweight. So what are the nutritional requirements in adolescence? So the adolescence is the second fastest stage of growth, second stage of childhood that has the fastest growth, second to infancy. At this point in time, they experience growth spurts. So it's also important to note that aside from the macronutrients, they require micronutrients like iron, vitamin A and C in adequate amounts. Sometimes some of these adolescents may require them more than others. For instance, those that are in sports or those that have any form of eating disorders, because we are talking about obesity. There are also disorders that come with the lean, those that are on the lean side, yes. So, or if they are pregnant, or if they are under any special diet for whatever reason, they would require particular attention to their nutrition. So in terms of calculating the caloric requirements in adolescents, so they would fall into this category, those that are 20 kg and above. Generally, it's 1,500 calories plus 20 kilocalories per kg per day for every kg above 20. And so when that is done, that will bring the general caloric requirement in a day for a female to be about 2,200 calories for a female, and a male, the maximum of 3,000 calories. Okay, and it's important to know that the food choices that adolescents make, they're also affected by trends. Okay, so that's why I said appeal for food. So when they see something advertised or when something is trending, any kind of drink or food, they may choose that food choice more than what, excuse me, they would ordinarily have chosen. So that's why they need to be encouraged to make healthy choices, especially those that are already having the problem of obesity. So currently, the prevalence of adolescent obesity is rising exponentially. I chose to start with the developed country and then come home so that we can appreciate how it relates with us, and that's just briefly. As it stands today, 20.5% of adolescents in the United States are obese, and 9.5% are morbidly obese. And the factors that have been found to play a strong fit are African Americans who are distant relations and low socioeconomic class. And we can appreciate what is happening in the country today. So that's why this is something that we need to pay attention to. Now in Nigeria, there's a systematic review published, and the values given were quite interesting because as of 2009, only 0.3% of adolescents were found to be obese. However, by 2012, that's a decade more ago, they were already up to 5%. So we can appreciate the exponential increase in obesity in adolescents in our environment. So, but now there are risk factors that increase, there are factors that increase the risk for obesity in an adolescent. For instance, if the parents are obese, then that particular adolescent is already at an 80% chance of being obese as well. Then environmental factors, feeding patterns, and psychological factors, all these contribute to the risk for obesity. Now, aside from that there are factors that actually cause obesity. No matter what anybody's genetic orientation may be, once there is increased intake beyond what you need or what you born, obesity is going to be the end result. So whether the intake is for social or maybe as a result of drugs the person may be on, as long as the intake exceeds expenditure, obesity will be the end result. Then when there is reduced expenditure, when the lifestyle is sedentary, like we can appreciate what is going on today, a lot of screens. In time past, people would go out and meet their friends and engage one another, but now they sit at a place. So decreased energy expenditure. Then organic causes also contribute to obesity, but that will be to a lesser proportion. So what are the complications that result from obesity? Medical complications like hypertension, diabetes, asthma, obstructive sleep apnea, PCOS, early menarche, gynecomastia. Then the psychological trauma. Today, children really can be quite mean today. So the bullying and the low self-esteem and the depression that comes from it, they are serious issues. And another interesting thing is that children that battle obesity in childhood, they tend to carry it into adulthood. So this slide is just one that I put up to draw attention on some symptoms, obesity-related symptoms. So this child is obese, right, and is already depressed or is experiencing bullying. It could present with school avoidance, sleep problems, nervousness. Okay, those ones that have the condition to a certain degree could come with symptoms of asthma. Those that have obstructive sleep apnea could come with daytime somnolence and poor performance in school. And those that are already developing cholelithiasis and problems with the biliary tree can come with upper abdominal pain, especially postprandial. So sometimes when they come with some symptoms, when you look at the child and you see that this one is obese, especially those ones that are like moderate and severe obesity, you really have to try to take, connect the dots. The obesity may actually be the underlying problem. And then moving on as well, features of type 2 diabetes, hirsutism, acne, irregular menstruation for the females that have polycystic ovarian syndrome and all that. Those that have genetic disorders may actually have primary amenorrhea. And then especially in the musculoskeletal system, one major illness that could be quite debilitating is slipped capital femoral epiphysis, because it can actually be quite crippling if it's not identified and managed well. And then various degrees of micronutrient deficiencies like BPD, so they could suffer various levels of fatigue and muscle aches and pains. So in terms of assessing an adolescent with obesity, definitely we want to take a very good history and do a detailed examination. We need to look out for the blood pressure, look out for the cardiovascular system. When we're testing, we want to look out for this lipidemia, fatty liver disease, type 2 diabetes, so that these things can be tackled early. So by way of physical examination, pointers that you could find that would heighten your suspicion, if the blood pressure is elevated, or if you have features of insulin resistance, like they have acanthosis nigricans, or there is hirsutism, or there are violaceous striae pointing to like an underlying pathology, that is the result of the obesity. If they have any form of cranial nerve deficiency, or there is significant tonsillar hypertrophy. And then when it comes to inflammatory cysts and masses in those friction areas, hydradenitis can be something that is very recalcitrant to treat. So far, a causative link hasn't been established between obesity and LEAD, but then they can coexist side by side. So if they usually in those that have more severe obesity, in addition to psychiatric or psychological impairments. So, but if they are able to lose a few kgs, the presentation of hydradenitis actually gets better. And then neck swelling, wheezing, abdominal tenderness or hepatomegaly, right? Undescended testes would point to genetic factors like Prader-Willi if it's a male. And then bowing, abnormal gait in an obese adolescent should draw your attention to slipped capital femoral epiphysis, and then other features that may point to underlying genetic syndromes. So, what are the goals of therapy when you're managing an obese adolescent? The overall aim is to reduce the excess body fat, and this is for health reasons and not for cosmetic reasons, because I've seen a few or some adolescents in my young practice that now went from being obese to developing eating disorders. They didn't just eat, anorexia and the rest of them. So it has to be emphasized that the weight loss is actually for health reasons. And reducing weight by 5 to 10% can result in very profound health benefits. You need to set goals. And one of those goals is those that get towards preventing any further weight gain, right? You want to prevent further weight gain. And then, of course, if there are already obesity-associated comorbidities, those would also be addressed. So it's important for us to buttress the fact that obesity is heterogeneous, and there is no single cure. And it's not the treatment or the management is not a one size fits all. So you have to keep tweaking it depending on the patient in front of you. You have to be aware that psychological and emotional issues can actually be a barrier to getting good results. So if you're unable to figure out that this child is depressed or is anxious or being bullied, the child can continue to eat food, comfort eating, and all the things that you're doing will seem not to be working. In the course of the management, the long-term basis is to cope with the weight situation. Yes, because like I said before, sometimes they lose weight and they gain weight. Okay, so you have to establish a coping strategy for the adolescent and the family so that any management that you're giving can work. And like I pointed out at the onset, sometimes they have intermittent periods of remission and relapses. So you have something like weight cycling develops. However, this weight cycling is not the best. So that's why a lot of counseling and a lot of support have to go into encouraging that adolescent to do what is needed to get to the right way, because the effect of cycling weight, the weight cycling has not been established, but it's noted that maintaining a healthy weight or maintaining a certain weight and then going down is better than going up and going down. So as pediatricians, what's our role in the care of adolescents? So because we see them one-on-one in the clinic, the first thing is that we're going to be the ones to initiate their care, and we're going to be the ones to coordinate their care. We have to do a lot of encouragement and reassurance, because if the adolescents and their family adhere, because they are growing, so their body is actually malleable. If they can adhere to the plan that you people make, the results will be seen. So you have to encourage and engage the entire family. Qualitative changes need to be made to the diet, okay? Because in addition to weight loss, the child also should be able to maintain linear growth. If that is not done, the linear growth of the child is going to be stalled. So all those extreme diets that adults can engage themselves in to lose weight acutely is not encouraged for adolescents. A lot of behavior modification, that's the bane of therapy in adolescent medicine. Increase activity, change eating habits, meal patterns, limit juice and sugary drinks, and then ensure adequate sleep. Not sleeping well alters the circadian rhythm and the hormones and the steroids that are released. So these things have to be emphasized. It's actually a multidisciplinary care. At some point in time, you may need to involve the dietitian, you may need to send to the mental health physicians if there is need, pediatric endocrinologists if there is a need. So, and even the orthopedic surgeons, if that's the pediatric pulmonologists, if they have, if their lungs are so deconditioned that they need respiratory assistance. And it's important for us to know that surgery and pharmacotherapy are at the bottom of the care, because sometimes you find those, the family and the child, when they come, that's just what they are looking for. They want to know what are the options, especially those that can afford it. That's what they are looking for, but it's actually at the bottom, it's at the outer gates of the therapy for obesity in adolescents. So we encourage increased physical activity, at least 1 hour a day. And this is beyond, aside from exercising, activity, in other words, walking, instead of being driven to school, walk to school, like move as much as you can. And very important to reduce screen time, because being in front of the screen is a major factor that is propelling adolescent obesity. So reducing screen time, and also I mentioned energy expenditure. You want to create a sort of energy deficit where at the end of the day, in a month, they are able to lose 1 to 2 kg. And ultimately, when you set your goals, you have to set short-term and as well as long-term goals. And the long-term goal ultimately is that at the end of the day, the adolescent should get below the 85th centile for age and gender and should stay there. And I've brought out sleep management again because it's quite important. For some of us that have adolescents, you wake up in the night and they are awake, peering at a screen. So it's very important. Sleep management is very important. Remove all screens from their bedrooms. Remove the clock. Let the clocks from facing their beds. Let reading be done outside of the bedroom so they can have a reading area. So whatever they do in their bedroom is just for sleeping, not eating like within 2 hours before bedtime. And if they lie down and they are unable to sleep, they can just walk around or maybe take a warm bath or maybe have a cup of warm milk and then come back. But essentially, the bedroom should be dark and soundproof and quiet. So everything that is going to encourage them to fall asleep. And as pediatricians, we have to also prioritize parental involvement. It is very important because in our environment, adolescents are still dependent. And some of the plans that we make, they cannot achieve it if their parents are not fully on board. So the parents are usually the ones that buy the food ingredients and they make the meals. And this would be quite unfair as a parent for you to cook your food filled with all the good oil and all the salty spices and all the things that the child doesn't need, and then you make it a bland meal for the child. And while you're eating one, your child will be eating another thing in the name of weight loss. It's not going to be sustainable. So the parents have to be fully engaged and make the changes family-wide, so that the child can feel encouraged. Fruits and vegetables have to become a major part of the diet in the home. And empty calories or calorie-dense food like cookies and soda and all those high-fat food really need to be eliminated, and juicing. Juicing is not really the best, Sweetened beverages, you don't need it because when you take juice or any beverage, it's just fluid. Within a few minutes, if you're hungry, you become hungry. So it's preferable that you eat the fruit. You want to eat orange, eat it with the whole fiber and everything. Is filling, is satisfying than juicing. We have to point out that there is a need to avoid fast food. Fast food is cooked in such a way that it will appeal to the audience, appeal to people to come, but it's not the healthiest food. They use unhealthy oil, a lot of spicing, a lot of salt, which will be working against the aim in terms of losing weight, okay? And the family has to be encouraged to sit down together for family meals. Let it be an event, a time for them to bond, discourage eating in front of the TV, eating while playing video games or watching screens, because these things reduce the awareness of how much you've eaten. When the adolescent is watching TV and eating, he could eat up to 3 plates without being aware. But when the family is sitting together and they're sharing it as a moment, it helps to control the portion sizes. And so that brings me to serving appropriate portion size. Serve smaller portions at once. Instead, let the child ask for more. Okay, so that's preferable than mounting a huge heap of food. Yes. So that is what we encourage as pediatricians. And so that also brings me to the healthy plates. This is something that we need to share with the adolescents and their parents and their families. So this is what the healthy plate should look like. Half of the plates at every meal should be fruits and vegetables, and the fruits should consist about 10 to 15% because the fruits contain a lot of sugar, and the sugar is what we don't want. Though they are healthy sugars, but still, so they contain a lot of sugar. We don't want the adolescents to be weak, that they cannot keep up with the high pace of their activities. For them, we want to achieve an energy deficit so that they can lose weight and remain healthy. So the vegetables should be about 35%, 30-35%, and the rest should be fruits. And then lean protein should make up a quarter of the plate, and then whole grains or complex carbohydrates should be advised to make up the rest. And then cook with healthy oils, the ones that have the monounsaturated fatty acids, so like the seeds, soy oil, and original groundnut oil, and not just the hydrogenated or saturated oils that are commercially or commonly available. And also, this is another pictorial that also, makes the proportion very clear. So we see the vegetables, the proportion should be more than the fruits. And then the protein and the grains have almost the same proportion, maybe about 20%. And this one is about 30%. Okay, so when we are treating adolescents that have obesity, generally, the treatment, some people have more phases, but for ease, I just take it in 2 phases. The first one is to induce weight loss, while the second phase is to maintain the weight. Okay, so when you're inducing weight loss, like I've been saying, you need to create a there needs to be a caloric restriction and energy deficit of about 500 kilocalories in a day. In other words, the child should be expending more than he's taking in. Not necessarily because he or she is taking less, if you use the healthy plate pattern, they can eat as much as the volume of their tummy wants to eat, but there is essentially a caloric deficit, so that when they engage in the activity of going to school, walking around at home, and doing their daily exercise, they are losing more than they are gaining. And the challenge now when you're inducing weight loss is that we do not want to lose lean body mass. So if you do just dieting and you're not exercising, you begin to lose lean body mass. So there is need to exercise, both aerobic exercising and resistance training. And so this phase will usually achieve some weight loss until there is a plateau. There is a plateau. If it is assessed and you say, okay, I still want to achieve more weight loss, when the plateau occurs, usually around 3 to 6 months, then you can retweak the diet and increase the exercise while maintaining hydration. Okay, so this is essentially what to do to induce weight loss. So by the time there is a plateau, you can, and if you're satisfied, the child has lost about 5 to 10 kg, you now want to maintain. So you can take it in a step of induce weight loss, maintain, induce further weight loss, maintain. Because if you do induce weight loss, you get to the plateau and you want to induce further weight loss, it may be very stressful for the child and their family. So if you induce, you maintain, like a stepwise manner. And then when we are comfortable at a certain weight, we can induce further and then maintain and induce further. And that's a more achievable way to manage obesity. And so we want to prevent weight gain. So there is something that is quite complex that is still being elucidated. The moment weight loss occurs, the whole system of the adolescent, even as an adult, is trying to make this person to regain the weight. It's like a body conspiracy. So if the child and the family, they are not aware, they find that in 10 years' time, when this child may now be an adult, all the weight lost has been regained. So that is something that you have to be aware of, so that you counsel, so that the adolescent knows that everything that is being done has to be maintained steadfastly. Okay, so there is no evidence that this neurobehavioral phenomenon that happens diminishes over time. So as long as that's why prevention, they say, is better than cure. So as long as the child has got to that level of being obese, or even an adult, and attains any level of weight loss, the whole body and brain, they are all conspiring to push you back to where you're coming from. So if there's any lapse, and the adolescent says, let me rest now. Have I not lost 10 kg? Let me just eat ice cream today. That's why you work so hard and you lose 5 kg and you just drink water with small sugar today. In the morning, the 5 kg is back. So it's a phenomenon that happens, so we have to be aware of it so that we can counsel the child and the family appropriately. So something that is also key when we are managing these adolescents is that we need to set goals. We need to set short-term goals. We need to set long-term goals. All these things we're talking about, you have to incorporate it in your counseling so that they will know that I just lost 10 kg and I've been able to keep it up for 3 months. Doesn't mean that's for the rest of my life. So they have to be aware and conscious. So goals, we want to improve the health status, not just to reduce number. We can reduce this weight in 5 to 10% of whatever the weight is at a time. Because for those that have class 2 and class 3 obesity, really trying to push them beyond 10% of the weight loss at any particular time is difficult. It may be so stressful, they may not cope with what it will entail. Whenever you have lost any amount of weight, maintaining it, you should be conscious of maintaining it. And increased physical activity is always very important in losing weight as well as maintaining weight loss. So the nitty-gritty when it comes to nutrition planning and diet composition, what we counsel is 3 meals and 3 healthy snacks. 3 healthy snacks in a day is important for weight control. We want to discourage prolonged fasting, skipping meals. Breakfast is very important. It's been found that those that have their breakfast are less likely to have obesity than people that do not. Contrary to some things I've heard, said in the clinic, they say if I don't eat in the morning, I'm able to control what I eat for the rest of the day. But that's just the mind playing tricks. Because at the end of the day, when you now eat 5 days worth of food. And when you eat so close to bedtime, melatonin and other nighttime hormones, they just conserve the calories and they cancel out the good work that you did during the day. So it's always best to have breakfast. Then also do some activity after you've had a meal, like in the afternoon, you've had a good meal. Do some activity, take a walk. It's advised to keep your body moving. Always avoid empty calories and calorie dense food. And then the aim is not for the child to become weak. There's some people that do this dieting and hunger has finished them. If you say even to pick pill, they cannot. So that's not the essence. So there should be adequate carbohydrate intake, because if the carbohydrates are not taken in well, the protein, the lean body mass will be lost. That's not what we want. And complex carbohydrates, they have low glycemic index, and they require some time to digest. So that means they maintain some satiety. That's what we recommend. So rather than taking all these processed sugars, things like the good old Gary with good vegetable soup, well made. Gary is good actually in good portion. Complex carbohydrate beans, those kind of soybeans, they are good and they can be factored in very well into the diet. You need to ensure adequate protein intake daily. I keep talking about maintaining the lean body mass, okay? And then the fats. While you don't take away the fats completely from the diets, diet schedules that are lower in their fat content are always better. And even when the fat is to be added, the healthy fats is what is advocated. I said it's a multidisciplinary care. So a dietitian might be needed to plan a good meal around what is available and affordable for the family. And then all weight loss diet, again, I have to reiterate, must be nutritionally adequate because adolescents are growing. I've had an adolescent that she just completely refused to eat. We had to counsel. And then by the time she ate a bit, she added a few cm, 1 to 2 cm, and she was so happy. So if it's not adequately managed, linear growth could be affected. And of course, at every point in time, we want to discourage extreme or fat diets. So physical activity, very important. We need to increase physical activity for the sake of fitness and to reduce cardiovascular risk. The activity has to be regular. It's not once upon a time kind of thing. So in 2 weeks, person will now go to the gym and work out for 10 hours until he has a muscle and cardiovascular crisis. 30 minutes in a day, ultimately to burn about 300 calories per day is what is advisable. So regular physical activity is what is advised. And then before any activity is prescribed, you really need to assess that individual to ensure their capability. So a treadmill test can help. You need to consider that, send to a cardiologist, pediatric cardiologist, to assess and know what is the amount of exercise that this child can tolerate. Okay. And exercise that is coupled with adequate meal plans is what is most effective in achieving the desired weight loss. Okay. Let's see. Okay, sorry, please. All right, so I mentioned this before. Continuous exercise, about 30 minutes every day. It doesn't even do 30 minutes in one stretch. It can be 10 minutes repeatedly. There are high intensity exercises, heat exercises that are done to align to people's physical capabilities. Maybe they're having knee problems or spine problems and all that. So there are so many of them out there. It's just to find the one that suits these patients well. So at least 30 minutes, at least 5 days in a week is what is required. And the energy expenditure. Initial goal is to increase your energy expenditure by 700 to 1,000 kilocal per week, or about 100 to 130 kilocal in a day. And so there are some gadgets that help, that count like the pedometer. So if this adolescent is able to walk up to 10,000 steps in a day, it's good. But I've seen a skit where the person puts the pedometer on a dog and the dog ran and came out and it was 10,000 steps. So, you have to counsel the child to not to play pranks, and try to do it as much as he or she can. I also want to emphasize the need for resistance training. Yes, so resistance training. So it's not just aerobic exercise that is here to reduce fat. Resistance training will also help to build the lean body mass. And they should engage in activities that they enjoy. What are those things? Do they like to play ball? Do they like to run? Do they like to do mountain climbing? So those things that they enjoy, they can choose what is available to them and engage in them. And so I've mentioned these activities. So you can have activity trackers, but you have to counsel them that they don't have to rely on the energy expenditure that are calculated by the activity tracker. Let the activity tracker just say what the person has done. I did 10,000 steps, that's fine, but they are not too good in estimating the amount of energy that has been expended. Now, moving on, I still have to talk to us about those medications that are used in managing obesity. Like I said, they are at the outer gate of the outer gate. They are not the first thing, they are not even the second. So they come in when you're dealing with recalcitrant obesity or people that have so deconditioned that they cannot engage in any form of activity to even initiate the needed weight loss, for the health benefit. They are unable to get there. So these are the people that, in addition to minimal activity and dietary modification, some of these drugs can be instituted. So it's not something we do arbitrarily. So there are 2 drugs. I don't know, I couldn't find anything about what the regulations say in Nigeria, but in the US, there are 2 drugs that are FDA approved for treating adolescent obesity. And those 2 drugs are Orlistat and Phentermine. Orlistat I know is available in Nigerian markets, but Phentermine, I have never bothered to ask about it. So Orlistat, it's a reversible inhibitor of lipase that prevents hydrolysis of triglycerides into free fatty acids, causing fecal fat excretion when you take a fatty meal. It's been approved in the treatment of adolescents that are 12 years and older, okay? And trials have been done that have found them to be safe in adolescents. And what this thing does, essentially, breaking it down in lay terms, is that when the person eats anything oily, you will not absorb it. So, but the only thing that makes adolescents and even adults to reject the use of this drug is that the person could just feel like fatting, good old fat, and it will just be oil. The oil will just pour out because it inhibits absorption of any kind of oil. And so they will soil themselves, and it causes a lot of bloating and flatulence, but otherwise it's good. Then the other drug, Phentermine, this is a sympathomimetic medication. So we know that sympathetics, they trigger the metabolism. So that's essentially what it does. But this one is approved for those that are older, 16 years and older, that are obese or they are overweight and they already have comorbidities associated with being overweight. Trials have been done that they've been found safe. However, there is no long-term data that I found about its use in adolescents. So there are still other drugs that can be used in treating obesity in childhood. But the thing to point out that these drugs, they find secondary use or off-label use in treating obesity in adolescents. So that means you have to counsel the patients and the parents if there is need to prescribe them, and if possible, they should have a written consent. But essentially, they are safe. So, glucagon-like GLP-1 agonists, that's like liraglutide and metformin, they are used in treating type 2 diabetes, but they have also been found, they have been useful in managing weight for those that have supermorbid obesity. And then topiramate is an anticonvulsant, it controls weight. Bupropion is an antidepressant. Then dexamfetamine, we know it's used for treating ADHD. It's also a sympathomimetic, so it's it manages weight, because even those that have ADHD, when they use it, sometimes suppressing appetite is one of the side effects. So that side effect is what comes in handy if you have to prescribe it for a child that has morbid obesity. Then there are some other combination drugs like the ones that phentermine, topiramate, and bupropion, naltrexone. Naltrexone is actually an opioid antagonist, sometimes used for substance use disorders, but then the combination has been found to work for obesity, and has off-label use have been found in treating adolescents that have obesity. So this is just for us to know if we have to manage any child that is at that level. And then the other treatment is bariatric surgery. We cannot say it doesn't exist. It exists, yes. So it's done for those that have terrible, see a child that is, an adolescent that is 400, 500 kg. So those ones are candidates. However, nobody ever does bariatric surgery de novo. Usually those ones are started on a diet. They are required to lose at least 50 to 100 kg first. They're started on a diet and they do minimal exercise. Even if it's just moving your hand with 2 kg dumbbell, they will be on some level of physical activity that they can tolerate. And then they will now be worked up for bariatric surgery. So especially those that have comorbidities, severe sleep apnea, because if you leave them, they will develop right-sided heart failure and pulmonary hypertension and a lot of other complications, poorly managed type 2 diabetes, and they're having recalcitrant and intracranial hypertension, and a lot of other problems. These ones, if they meet the criteria, they can have bariatric surgery. The surgery is not, as long as the child meets the criteria, regardless of what the bone age or the sexual maturity is saying, they can have bariatric surgery. And there are some contraindications to bariatric surgery. If the child has an underlying medical condition that is correctable, you have to do medical, non-pharmacologic, and even pharmacologic care first before you think about doing surgery. If there is ongoing substance abuse or substance dependence of any time, or there is psychiatric or cognitive impairment, these actually negates the adolescent for surgery, or if this adolescent is obese and pregnant, because the ability for the lungs to, and the cardiovascular, cardiorespiratory system to bear the weight of the surgery and the aftermath is the risk here. And so what are the options? There are so many options: the sleeve gastrectomy, the adjustable gastric band, the X and Y bypass. There are so many other options. So the best option that would put the child at the least risk will be chosen by the surgeon and you, the pediatrician, and then other management of the health team that are taking care of this adolescent. So this is basically caring for the adolescent, because that is what we do. Well, we can still do a lot of advocacy. We can do a lot of advocacy and the way food is advertised, but well, Nigeria, I don't know, but there's no effort that is lost, because sometimes these adverts, they create a mental picture in the mind of the adolescents. And so they feel that this thing, if I don't have it, if I don't eat this burger, this triple layer cheeseburger dripping with mayonnaise, I've not started. So, but then business has to go on, so counseling that adolescent to change their mindset and to establish deep-rooted behavioral changes that will last for the rest of their life. That is the bane, or that is the bedrock for managing obesity in adolescents. So in conclusion, obesity is a chronic disease. It's a chronic disease, and long-term strategies rather than short-term interventions are what would form the basis of your care. There are genetic risk factors. However, when you have healthy life patterns, they can compensate for those genetic risk factors. You have to really pay attention to psychology and the emotions and other environmental and physical barriers to your care, so that the good work that you're doing will yield results. You need to focus on health improvement, okay? For those that But the obese adolescents, especially those that are morbidly obese, even as small as she said, 5 to 10% can be your initial goal in weight loss, but even as small as 3% can can improve the health status. So at every point in time, your aim is to improve health. And the long-term target is for the child to get into the normal weight bracket, which is less than or equal to 25 kilograms per meter squared. Okay. So, but that's reaching that goal is not an acute thing. It depends on what the person's with. So if a child presents and is having signs of maybe exercise-induced bronchospasm or maybe signs of asthma, and the BMI at that point in time is 31 or 30, this person with judicious care can easily achieve 25 kilograms per meter squared. That's the ideal at a shorter time. But so if the adolescent comes and BMI is at 60, you see that this one really is something that is years, it's a lifestyle that, has to be maintained over a long period of time. So you need to focus on improvement in health and quality of life at all times. You need to correct disorders in eating, eating when it's not needed, unhealthy snacks, anything eating in between meals is unhealthy. So avoid hunger, starvation in the name of dieting, and then subsequent binge eating has to be discouraged. Meal replacements, the family has to help. Meal replacement that is affordable to them, as well as portion control. The adolescents has to be empowered to monitor what they eat. It's not their father or their mother that will do the thing for them. Their father and their mother are providing support, but they have to monitor self-monitoring of food intake, physical activity, and lifestyle changes. Exercise is not the only way. It's not the best way to lose weight. If we want to achieve good weight loss, maintain it and sustain it throughout the person's life course, it starts with counseling, it starts with addressing underlying factors, all those risk factors and etiologic factors, instituting adequate diet, and then exercise. So none can occur in the absence of the other. Then we have to also prepare our patients for the plateau. Some people, when they hit that plateau, they will begin to kill themselves. They will be killing themselves. No. So when you hit that plateau, maintain for some time. Allow your body to adjust. And then when you have adjusted, you can now set a higher goal and push towards it so that you don't tire. Those ones that want to lose weight from January to December, they're the ones that tire and they lose and they regain all the weight very quickly. Yes, so this is the end of my presentation. Thank you everyone for listening. I really appreciate this opportunity to be here. Thank you so much.
Thank you, Dr. Ogochukwu Ofiaeli. You have really done justice to this presentation, and I'm sure that you're looking at the chat as I am and seeing that people are happy with what you have presented. So she has walked the talk and she has given us an excellent presentation. Thank you so much. I dare say that a lot of what you have shared with us about our children, the children that we look after, also applied to us.
Yes, true, because it's the same principle even when you're caring for obesity in adults, just that in assessing adult obesity, there are some other parameters that you can bring into play, like the hip ratio, the waist ratio, and all those intricate details, and you can be a bit more stringent in diet. But when a child is growing, you cannot restrict quality, the micronutrients and the macronutrients. You only cut off the excess and what is not needed so that the child can maintain growth while losing weight.
Yeah. So many times, you have, one of those things you told us was about involving parents. And you also told us that many times when the parents are obese, then the likelihood and the tendency is for the children themselves to be obese. So how should we approach a case where you are dealing with an adolescent, an obese adolescent? The two parents are also there and they are obese themselves. Meanwhile, your patient is the adolescent. How do you handle cases like that?
Well, it's about counseling. It's about counseling. You have to, that's what we call insights. You have to have insights. So it's just about telling the adolescent, please, can you just excuse me a bit? I want to discuss with your parents, and the adolescent will step out of the room. And you tell the parents that we need to do this thing, but you have to come on board, do your own. Let's do your BMI first. You tell them, see your own BMI. You can see that your BMI is more than this, your child's own. You need to be alive for this child. You need to provide support. And you're the one that is bringing the money, the food in the house. So it's not just about this child, it's about the whole family. So you discuss with them, and then you now say, okay, young lady or young man, come back in. I'm done with your parents. And so the parents are prepared and they are aware, because sometimes they are not aware. They are looking at their child and they fail to realize that my own BMI is 500. Please, we cannot get to 500. We cannot get to 500 BMI, but my BMI is actually 38 and my child's own is 38. So that means we are all in the same category. So that's the only way. You have to counsel them to bring them on board.
Thank you. I see a question in the chat room asking about intermittent fasting. So what's your take on intermittent fasting?
Well, for adolescents, they should not miss their breakfast. If they are going to fast, they can fast at night. So they can have their last meal by 6 p.m. and then breakfast by 6 a.m., 7 a.m. Okay? So that's actually will help them burn calories. That's the fast that they can do. But if it's for them to do this 16-hour fast or 24-hour fast, because melatonin is released at night and they are growing, they have a lot of hormones that are running wild in their body. You have to be aware of that. So their body is not exactly that of an adult, not exactly. So we have to create scenarios that will help them, that are sustainable, that will not be psychologically traumatic to them. Many adults that do intermittent fasting, they go into it willfully. So the adolescent may not even be willing to fast like that, but then it's not healthy. Breakfast in the day helps to set the metabolism. So they need to have their, so if they're going to do that kind of fasting, to be at night, so they can have an early dinner. And then in the morning, they now have their breakfast like 7 a.m. So that will give them like a 12-hour fast while they are resting and sleeping. Yes, so that's what I would recommend.
Yeah, of course, the portion control also applies to the breakfast, even though they're having it early. Not that they will eat, the breakfast like the king, that like we hear.
Yeah. Well, ultimately, if a child is used to having 5 plates of food for breakfast, 10 for lunch and 20 for dinner, you cannot just come and bring 1 serving spoon and say we have started dieting. You're looking for trouble. So the thing is the content of the breakfast, because so you do portion control, but it's going to be a graded reduction. So when the food becomes healthy, you have a lot of fiber, you can grate green pepper, you can grate carrots, all those kind of things. Use the healthy plate pattern for all the meals. And so if they are taking things like carrots and green pepper and steamed cabbages, and they like it, and they want to fill themselves with it, it's acceptable, because that's vegetable. It just has minerals and lots of fiber. Then over time, you reduce the portion gradually until it's acceptable and they can eat the normal portion. But you can't just come to a child that eats so much at once and all of a sudden you starve the child. No. It's that those kind of things make the adolescent not to adhere to the meal plan. So everything has to be graded, step by step, gradually, until we achieve the aim.
Thank you. So somebody else is asking, between animal and plant protein, which would you advise for weight loss in adolescents? I know that you also talked about short and long-term goals, but I see that somebody wants to know. So maybe you could just emphasize on those short-term goals and those long-term goals. So the first question was about the choice between animal and plant protein, and the second question is about short and long-term goals.
Okay, well, animal proteins are high-selling proteins, but then they are what constitutes the lean protein. So on the plate, we saw that those lean proteins should be about 20% of the diet, because when you're losing weight, if you're not careful, you lose muscle mass. And these are adolescents and they are growing. We don't want them to lose muscle mass. So animal protein should be at least 20%. But then what we call plant proteins contain a lot of complex carbohydrates and fiber. So you have things like beans and peas. So those ones, they have some protein in it, but they have lots of complex carbohydrates. So it's going to be a good blend. So in the remaining 30% of the second half of our healthy plates, you can also incorporate good amount of plant proteins. Beans has a lot of carbohydrates. Incorporate a good amount of plant proteins to supplement the grains or the carbohydrates. So that's what I don't know if I need to bring
Yes,
up
I
the
think, you know, what many people don't know is that beans actually has about 70%, 60 to 70% of
Yes,
carbohydrates.
yes,
So
exactly. Exactly.
we need to also teach that, know that for ourselves, and teach it
Mhm.
to
Yes.
adolescents and their parents that beans is not all protein,
It's
as
not
many
all
people
protein.
say.
No, it's not. It's
Yeah,
not. And even when you prepare pudding or you prepare moi, all those things that we like, I will say it's protein. All the oil and all the rishi things that you put inside. Carbohydrates. Carbohydrates. So it's only the lean protein that you can really trust and say, I'm having protein. The animal-based proteins, they are padded with lots of carbohydrates.
Thank you. Now, many people also think that exercise, you know, alone will suffice for weight loss. I'm glad that you talked around that, and I would just add that really, if one wants to lose weight, 85%, 80 to 85% of effort is actually on what we eat. That 15%, 15 to 20% is what the exercise is what exercise contributes to weight loss. So my question for you would be that I'm aware that many parents take their children to the gym so that they can get exercise to lose weight. But I also know that some of them sustain injuries from the gym, in the name of losing weight. So what would be a word of caution to us, to tell the parents of these adolescents when they take their children to the gym for exercise? What should they avoid, in other words, so that we can prevent injuries?
Yes, I think that the word of caution would be to avoid extreme exercise, especially those ones that need heavy instruments. Outdoor activities go a long way, like walking or hiking, climbing, jogging, running, those aerobic exercise. Then if you want to do strength training, some strength training workout that you don't really need equipment, or if you use lighter dumbbells, to, do those weight things. But let the adolescents choose whatever exercise you introduce to that adolescent. If the adult, and before I continue, we need to assess, so, before you subject them to any form of exercise activity beyond walking, they need to undergo a physical examination and review by the cardiologist. They need to do a treadmill exercise to know what they can accept so that they don't drop dead there, from cardiac compromise. So it has to be graded. It cannot be anything that is physically and psychologically tormenting in the name of exercise. Like I watch some videos and I see those children doing those kind of things, and I get goosebumps all over. But an adolescent can still go into weightlifting as a sport, but it cannot be in the context of losing weight, in terms of an obese adolescent losing weight. So any exercise should be graded. It should be enjoyable to the adolescent, and it should be acceptable. They should participate in choosing which activity. And you can be rest assured that whatever they choose will be what their body can take. Yeah. So there's a question I omitted about the short-term and the long-term goal.
Yes.
Yeah. So the short-term goals that you can institute is eating right, those behavioral changes, aim of having at least a 500 kilocal deficit in a day, so that at the end of a month, you would have lost 1 to 2 kg. So eating right, behavioral changes, limiting the screen time, increasing activity. So when you limit your screen time, of course, then you see yourself walking around. So those lifestyle changes. Those are the short-term things. So at the onset, you give them short follow-up to see how they are coping with those things. And then the long-term goal could be, okay, you came in with a BMI of 45%. In the next 6 months, this BMI, we want to get it down to 40%. When you achieve 40%, you say, okay, now in another 6 months, we want to bring it down to 35%. Ultimately, the longest aim is to go below 25 kilogram per meter squared. That's our aim. That's what we aim for. So that's the long-term goal. So you have short-term are those day-to-day things that they do. And then the long-term is what is the ultimate result that you're trying to achieve. So that can help you or inspire you in creating those goals with the family. Sometimes when you make a particular goal, you see that the adolescent will even modify. If you say, okay, you exercise one eye, say, no, I can't do it. They say, okay, how about if you do 10 minutes? Okay, let's reduce it to 30. 10 minutes, 3 times a day. They say, okay, hey, I can do that. So you will walk around it and create the goal, and it's more acceptable to the adolescents and their family. Yeah.
Thank you so much. I see a comment really in the chat room that talks to us about discipline, and I think we both agree that discipline is very much needed. You know, when the aim is to lose weight in an adolescent, and as you said, that adolescent has to be well motivated. The role of the family and the pediatrician is to encourage, motivate, but the child has got to be motivated. There's no way around that. I see that we're running short on time, so I will just wrap up with 2 things, you know, that I will emphasize 2 things that you talked about. You talked about the family pot, and you did say that there should be no separation. So we should not say that because an adolescent needs to lose weight, the adolescent will eat something that is different from everybody else. So I think that is very important for us to be able to communicate to the adolescents and particularly their parents. There should be no such thing as different pots of food in the house. It should be everybody eating from the same pot. I also took away the fact that he said the bedroom should be enhanced for sleeping. And there should be no screens in the bedroom. So no screens in the bedroom. And as much as possible, that reading should also not be encouraged in the bedroom, so that the bedroom is what it's called, you know, is used for sleeping.
Yes, exactly. Now, before we conclude, that is sleep hygiene. We can go out of our way to look into sleep hygiene and research on it. So you have to emphasize sleep hygiene. The bedroom should be for sleep and sleep alone. So that when they lie down, they are not distracted and they can easily fall asleep. Very important in managing obesity in adolescents.
I thank you very much, Dr. Ogochukwu. Thank you. We have enjoyed from the wealth of knowledge and experience. Thank you. And to the coordinator, Dr. Ileto, I'd like to take to you what Dr. Ogochukwu has told us. Maybe another day we will talk about sleep hygiene. So on this note, I'll hand over to you, Dr. Ileto.
Thank you so much for having me.
You're welcome.
Thank you very much, Ronke and Ogochukwu. It's been a wonderful evening. I have gained a lot in the rooms. When I get to my house, I'm going to go and remove them. And I'm sure there'll be a lot of resistance from the adolescents in the house, but I mean, it's for their own good. Thank you so much.
Thank you, sir.
You took on this assignment at very short notice. Because of PANCOF, we're not sure whether this will hold, but we started discussing on Monday, and you assured me you are ready. And I'm so glad that you've been able to put this together. A big thank you. We will come back again. And adolescents. So maybe that's something we'll start looking at in the future. But a big thank you to you for the wonderful presentation. Just before we round up, I'd like Dr. Mbolaji Lawal to say 1 or 2 words. Dr. Mbolaji Lawal, sir.
Yeah, thank you very much. It's been a very nice afternoon. Thank you so much, Dr. Ofiaeli. Excellent job you've done. And Dr. Akinola for very ably moderating the session. Everyone has been attentive and the contribution has been very, very good. Thank you very much indeed. I like what you said at the beginning, that if the child is looking well nourished, it is already probably a bit overweight. And it brings to mind the attitude of many Nigerians to this weight thing, you know. It seems like people generally like you to be a little bit robust in your weight. Because if you go down to the recommended weight, the normal BMI, people may start asking you, what's wrong? Is there a problem or something like that? So I think we need to have a lot of education to people on this matter. And so just on a light note, the child on the poster, looking at his tummy, he looked very affluent, like a politician, a politician somewhere, very affluent tummy. So what we are saying is that that kind of tummy is not necessarily evidence of good living. You know, when you see it, you know that the person is either overweight or actually obese. So thank you all very much. It's been an exciting afternoon altogether. Good afternoon.
Thank you very much, sir. And once again, I want to thank all those who joined and who contributed to the success of this presentation. Dr. Akinola, thank you very much for moderating. Ogochukwu, once again, a big thank you to you. And to everybody who will meet last Thursday in the month of February.